Hello, everyone, and welcome to the coding portion of your certification management program. My name is Amy Premitz, and I am the Director of Coding and Revenue Integrity for the Houston Methodist Physician Organization. Just to give you a quick background and introduction on who I am, I have actually been doing physician coding and billing since 2001, and I have worked with physicians and medical groups from Wisconsin, Chicago, and now I'm in Houston. I have been doing multi-specialty physician coding since I started coding back in 2001, and I'm hoping through the courses that we're offering, I'll be able to share some insights and knowledge that I have gained throughout the years and hopefully arm you with everything that you need to know as far as it relates to everything coding. So with that being said, let's go ahead and jump into our first module for this class, and we are going to have an overview and presentation on coding classification systems. On the agenda for this class, we're going to talk about ICD-10-CM, CPT codes, and HCPCS codes. ICD-10-CM and PCS. So ICD-10-CM is used to classify diagnosis codes and actually became effective in October of 2015. So it is still a relatively new coding system that we started using back in 2015, and it completely changed the landscape on how coders work. ICD-10-CM, as I stated, is used for diagnosis coding, and ICD-10-PCS is used for coding procedures in the inpatient setting. For the purpose of this class, we are going to focus solely on ICD-10-CM because that's what you'll use as a physician when it comes to assigning diagnosis codes. ICD-10-PCS is used for coding procedures in the inpatient setting, and that's not something that you'll have to be overly familiar with. What you need to really concern yourself with is how you document your procedures in the facility setting so that inpatient coders can assign ICD-10-PCS procedure coding appropriately. ICD-10 was created and formatted to report more detail and more specificity for the codes. Prior to ICD-10-CM, we used ICD-9-CM, and the code set did not allow for real, true, accurate reporting, and ICD-10-CM allows us to better reflect the severity and complexity of services provided. It is focused on current healthcare trends and really looks at outcomes and quality, and it allows for a better ability to compare coding information within the international medical community. We were actually the last country in the world to go live on ICD-10, and many countries at this point are already starting to look at moving forward with ICD-11. It's designed to facilitate future code expansion, and we actually just saw this with the institution of a new code for COVID-19 that became effective on April 1st of this year. Usually, ICD-10 codes do not update until October of every year, but this year, with everything that's happening, there was an exception that was made, and the exception was for COVID-19, and we now have a new diagnosis code that we use to report COVID-19. When we select ICD-10 codes, there's a way that we go about doing this. And when you look at an ICD-10 book, it actually consists of an alphabetic and a tabular index. As coders, we start by looking for a main term in the alphabetic index, and you can think of this similar to a dictionary. Once we look up our code in the alphabetic index, we then flip to the tabular index, and we look at the tabular index because this provides us additional details and explanations for code assignment. Code assignment is, of course, based on final supporting documentation, so you always want to make sure that your documentation is 100% clear and accurate in order for a coder to assign the best ICD-10 code for the service provided. We're going to select the most specific code applicable to the encounter, and we're going to pay attention to things such as laterality. Is this the first time that you're seeing the patient for a particular injury? So we're going to look at, is it a initial encounter, a subsequent encounter? We're going to look at, is this a sequela to like a stroke, for example, things like that. When possible, we want to refrain from using unspecified diagnosis codes. Unspecified diagnosis codes can cause some concern and some issues with getting claims paid. However, when it is appropriate, we may have to resort to using an unspecified diagnosis code if we just don't know what is the true diagnosis for the patient at the time of the initial encounter. If a definitive diagnosis code is not yet available, we will utilize signs and symptoms that are present at the time of the encounter. For example, if a patient is coming into the emergency room with a chief complaint of chest pain, at the initial time that the physician assesses that patient, you're probably going to decide to do various workups such as chest x-rays, labs, EKGs, all sorts of different workup to come up with a final or a definitive diagnosis for that patient. So if at the time of the initial visit or the initial consultation, all we know is that it's chest pain and we don't know what is the driving factor of that chest pain, then we'll utilize that sign and symptom and code that as chest pain. Another good example in our current state is if a patient is coming in with shortness of breath, fever, dry cough, we may not know if that patient is a true COVID-19 patient. So at that initial visit, while we're waiting for all of our testing results to come back, we may resort to coding the signs and symptoms of cough, chest pain, shortness of breath, those types of things for that first visit. ICD-10 code structure. So when you look at an ICD-10 code, it will contain a minimum of 3 characters, but may go up to 7 characters. It's just going to depend on the diagnosis code that we're assigning. So here on this screen, you can see what a typical ICD-10 code may look like. We have our first digit, which is always going to be an alpha code. And in our current state, actually, we now are utilizing the U diagnosis codes because that is the diagnosis code that we're using for COVID-19. So prior to April 1st of 2020, we did not utilize any U diagnosis codes, but because ICD-10 is structured to allow for that future code expansion, we now have a U diagnosis code that we are using. The second, third, fourth, fifth, and sixth digits will always be a numeric digit. And then the 7th digit, which is not always present on a code, is going to be an alpha code. So A, B, C, D, something along those lines. The 7th digit code is usually used to define things within our orthopedic section or our OB-GYN section. So for example, a 7th digit extension in orthopedics might be used to define fracture care. So is this an initial visit for fracture care? Is it a subsequent visit for fracture care? We also use the 7th digit to define if the fracture is open, closed, if it's healing, non-healing, those different types of things. And in OBGYN, we use the 7th digit character to define the trimester of the pregnancy. We can use it to define the number of fetuses for the pregnancy as well. If the code is only, let's say, a 5-digit code, and we require a 7th digit extension on that code, you may see us use a placeholder X character. And the reason why that's there is, again, to allow for future code expansion in ICD-10. Some general coding guidelines to think about when you're documenting and how we go about assigning an ICD-10 diagnosis code. Again, signs and symptoms. We will report signs and symptoms only when a precise diagnosis cannot be made. So those are instances where we're waiting for additional diagnostic testing results to come back. We do not want to assign a sign and symptom diagnosis code if it is a part of the normal disease process. A good example I can think here is if the patient has been previously diagnosed with Alzheimer's disease, we may not want to code memory loss along with that visit because the memory loss could be considered a sign and symptom of the Alzheimer's. However, reverse of that is if the diagnosis is not a normal part of the disease process, then we can code and should code that sign and symptom outside of the chronic disease code that we might be adding. We always want to make sure that we pay attention to the level of detail and code to the highest level of specificity available for that diagnosis. We can do multiple coding for a single condition, so we might use additional codes as necessary, and we want to pay attention to prompts within ICD-10. A good one here, actually, again, bringing it back to our current status, COVID-19. So we might have a patient that is COVID-19 positive, and then they might also have an underlying pneumonia related to the COVID-19. So for that, we would go ahead and code the COVID-19 diagnosis in addition to the pneumonia. There are prompts in ICD-10 that say to code first to the underlying conditions. So again, COVID-19 is a good example of this because if the patient has pneumonia that's related to COVID-19, ICD-10 will prompt us to code the underlying condition first, followed by the additional diagnosis. So in this instance, we would code the COVID-19 first, followed by pneumonia. There are combination codes in ICD-10. So what ICD-10 actually did that's different from ICD-9 is that we took a multiple diagnosis codes and we created a single ICD-10 code. So you can have one ICD-10 code that classifies a number of different conditions that's going on, that are taking place or going on with the patient. A good example of that would be looking at your diabetes codes. So if you have a patient who's got diabetic neuropathy, in our previous state in ICD-9, we would have coded the diabetes and the nephropathy separate. Now in ICD-10, we're going to have one single diagnosis code that defines diabetic nephropathy. And it's again one diagnosis code, so we went from coding 2 diagnosis codes in the past to coding just one diagnosis code in ICD-10. For acute, subacute, and chronic conditions, we're always going to assign the code for the acute condition followed by the chronic condition. So ICD-10 medical necessity, let's talk about this because this is very important, especially for a lot of you that are in this class today. In case you don't know what medical necessity is, medical necessity is a United States legal doctrine related to activities which may be justified as reasonable, necessary, and/or appropriate based on evidence-based clinical standards of care. That's a lot. So what does that really mean? Medical necessity is something that is often driven by the ICD-10 code selection. So the ICD-10 code selection is going to define the medical necessity or the necessity for certain diagnostic services to be provided. Payers have actually created coverage policies based on standards of care and medical necessity. So this is something that's very important for a lot of our subspecialists to really think about, and cardiology is one of those areas. Many of the diagnostic testing services that may be ordered in the cardiology arena do have to have specific ICD-10 codes that support medical necessity for that service being rendered. Local and national coverage decisions are published by CMS and define medical necessity for various services. You can go to your local CMS website and search for local coverage decisions and national coverage decisions. And what these things will do is they will give you the background information on different studies and whatnot that have been done to support the medical necessity for services that are rendered. In these local coverage decisions and national coverage decisions, they will also give you the list of CPT codes that are impacted by that policy, in addition to the list of ICD-10 codes that are required to be reported to support medical necessity for those services. Services that are considered not medically necessary as defined by policies will be denied for payment. So again, it is pretty important to understand that for many of the diagnostic testing services that exist out there, you do have to have a diagnosis, so an ICD-10 code that supports medical necessity for the service if you want to receive payment for the service you have provided. So let's switch gears a little bit and talk about ICD-10-CM and HCC coding. So this is something that's up and coming and a little bit newer in the medical coding community, and something that's pretty important for a lot of our primary care physicians to think about. HCC coding stands for Hierarchical Condition Category. And it really ties into risk adjustment coding and looking at those value-based payment models. This allows for CMS to pay plans for the risk of the beneficiary they are treating. So if you have a beneficiary that has multiple chronic conditions, they're typically a higher risk patient for you. They take more time, they take more resources. So the more often you see that patient, and actually not the more often you see that patient, but seeing that patient annually at least, trying to keep them healthy, keep them on their standard medical treatment options, their medical treatment plans, keeping them outside of the hospital. You want to see those patients at least on an annual basis, because again, they are higher risk patients, and you can actually receive some value-based payment incentives for seeing these patients on at least an annual basis. Payment is based on patient demographics, disability, financial status, institutional status, and diagnosis. HCC diagnosis codes, as I've stated, must be reported once annually, and CMS will reset that reporting every year. You want to document all diagnosis codes that coexist at the time of the encounter and require or affect patient care, treatment, or management. And we'll take a look at some examples in upcoming slides. So here's an example. A patient presents for follow-up for diabetic, PVD, atrial fibrillation, and hypertension. Patient is doing much better in keeping control of the diabetes. Recent A1C is 7.1. However, intermittent claudication continues. We see that we have documented vitals. We have a documented examination on the patient. And then for the assessment, we've got diabetic PVD. We want the patient to continue to monitor blood sugars, continue taking their metformin. The AFib, continue the amiodarone. Hypertension, stable on Norvasc. The patient is status post-amputation, right great toe. Continue to check both feet regularly, wash properly, and wear the prescribed shoes. So when we take a look at this one, we've got a diagnosis for diabetic PVD. We've got atrial fibrillation, hypertension, and we also assign the diagnosis code for status post-amputation of the right great toe. In this particular example, each diagnosis code that has been addressed, it can be mapped back to an HCC code. So this is just something I like to throw in there. So with ICD-10 codes, you know, I do hear a lot of times that physicians don't like how many times they have to click in their EMR system. So it's just a little bit of a funny. I hear there's a new ICD-10 code for carpal tunnel syndrome caused by clicking too many times in the EMR system. And then the other one I just like to throw in there, crushed by an alligator. There is actually an ICD-10 code for that, and there's an ICD-10 code for just about any occurrence or cause of injury that you can think of. So it is true what they say, there is an ICD-10 code for just about everything. So at this point, we're going to switch gears. We've talked about ICD-10 CM coding, which is the coding classification system that is used to define your diagnosis codes or tell the reason why you saw the patient that day, either in the office or in the hospital or in consultation, whatever it might be. So going from ICD-10, the reason why we saw the patient, now we're going to switch gears to CPT, or current procedural terminology, which explains to our insurance companies what you actually did for the patient or the service that you provided to the patient. So CPT takes the written documentation that you've provided, whether it be a progress note, a procedure note, an EKG, etc., and it turns that written documentation into a professional service numeric designation that is reported to insurance and various other agencies. It represents, or CPT represents, both diagnostic and therapeutic services. CPT is a 5-digit system for coding systems, and it also consists of 2-digit add-on modifiers, and we will take a look at both the 5-digit system and the modifier system. It is the system of choice by CMS, and because it's the system of choice by CMS, we do use CPT codes to report to all insurance payers. CPT consists of 3 levels. We have our level 1 CPT category, which is created and maintained by AMA, which is the level that you will become very familiar with over time. We have level 2, which is CMS designated codes and modifiers, and you'll actually become pretty familiar with this as well, because we will talk about some G codes that CMS has created and how you apply those in your everyday practice. And then we have level 3, specific codes to regional fiscal intermediaries or individual insurance companies. We actually don't do a lot of level 3 CPT code reporting. We were going to focus solely on level 1 and level 2 CPT codes. CPT is divided into sections. We have our evaluation and management section, and these are physician professional services. We are actually going to do an in-depth deep dive on evaluation and management in this series, but that's going to be a separate presentation, and that's going to be hopefully face-to-face with everybody and the synchronous portion of the coding module. We have anesthesia, surgical, which in our surgical section of CPT is further divided into the different body systems. We have our path and lab CPT section, radiology, and the one thing that I do want to mention about radiology is that it also includes services for radiation oncology, and within the radiology section too, you will see a lot of different cardiovascular services that are provided, especially nuclear stress testing. And then we have our medicine section. And medicine includes our coding for infusion. It includes most of our coding for cardiology with your cardiac catheterizations. It includes your cardiac echoes as well. And then under medicine is also where you find your psychiatric codes for things such as initial diagnostic evaluations, psychotherapy, and neuropsych testing. In the CPT surgery section, a couple of things I want to note here. We will always start with a completed operative report. We will never assign a CPT code based on a brief op note or a preliminary op note. We will never assign a final CPT code for billing based on what was pre-authorized, because we know that things can change from what was pre-authorized to what may have happened when you actually got the patient into the OR and opened them up. So we will never assign a CPT code or even diagnosis codes for that matter until the operative note is complete and authenticated. We are only going to code what has been documented within the body of the operative note. So from time to time, coders may come back to you and query you if they see something that is potentially missing. You always want to confirm the pre and post-op diagnoses, and they can be the same or they can change based on what you discovered when you got into the operating room. Keep in mind separate procedures. There are CPT codes that are defined as separate procedures. Separate procedures cannot be billed with other CPT codes. Separate procedures are exactly as they sound, completely separate and only billed when it is the only procedure that you performed on that patient in that session. We're going to use the comprehensive code to report the service rendered. We do not want to unbundle services that have a higher level code, and we'll talk a little bit more about bundling and unbundling in some upcoming slides. And you want to understand what is included in the global surgical package. So when we talk about the global surgical package, it includes all the local infiltration, anesthesia, blocks that you may perform on that patient. Subsequent to the decision for surgery, one related E&M service on the date or immediately before the date of the procedure. And what this really means is that if you see the patient in the clinic or office today in consultation and decide based on your evaluation that the patient is going to have, let's just say, a total knee replacement, the decision for surgery is made within that encounter. You can bill for that E&M service at that time the decision for surgery is made. Now, let's say the procedure is scheduled for 3 weeks out and the patient comes in the day before the procedure for preoperative H&P. That preoperative H&P that day before the procedure is not allowed for separate billing because it is considered a part of the global surgical package. The decision for surgery was made 3 weeks prior. Any E&M or evaluation management service that takes place related to that decision for surgery is not separately billable. Immediate postoperative care, including dictating your op notes, talking with the patient's family, maybe talking with other providers, all of those services are considered bundled in the global surgical package. Writing your orders, evaluating the patient in post-op areas, and then of course your typical post-op follow-up care, including complications that can arise from that procedure, are all considered bundled into the global surgical package. One of the things to keep in mind is that typically the patient's in a global period, 90 days post-op of a major procedure. So any service, evaluation management service that you're providing to that patient that's related to that procedure within that 90-day post-op period is not separately billable. However, if the patient has a new problem that arises and that new problem is unrelated to the surgical procedure that you provided, then we can bill an evaluation and management service, and we would report a modifier, and we'll again talk about the modifiers a little further along in this presentation. I do want to touch on a concept of National Correct Coding Initiative, or NCCI edits, because this is something that a lot of providers do actually struggle with, and it can create some conflict between coders and physicians. So I do like you to have an understanding of what the National Correct Coding Initiative is and what it can mean to you. This is something that is published by CMS, and it is used very heavily by CMS. One of the things that I do want to point out here, though, is that it is also followed by most commercial insurance companies. So even though it is a CMS system or a CMS policy, a lot of our commercial insurance companies take what CMS has published and apply it to their rules and their claims processing as well. CCI actually defines code combinations that are restricted by payer and CPT coding guidelines. They are used to define codes that are included as part of a more extensive procedure. They are procedures that represent two methods of performing the same service. And they are procedures that cannot be reasonably done during the same session. They are procedures that represent medically impossible or improbable code combinations. So when we have a CCI edit or rule that is in place, it means that you're going to code for the most extensive CPT code available for the procedure that you did. A good example of this would be in orthopedics when we talk about our shoulder procedures. When we talk about the shoulder, we know that there are 3 separate compartments within the shoulder, and a lot of times we might be doing different procedures within the different compartments. So if you do the same procedure, or if you do different procedures in one compartment, but the one procedure is a component of the more extensive procedure, then we're going to code that more extensive procedure CPT code. We would not code for the lesser extensive procedure because it's considered a part of that more extensive procedure. If you tried to code for both services, it would be considered unbundling of services. So we always want to code for the most extensive procedure that was performed and documented for that patient. A couple of CPT coding words that I want you to think about, things that you're going to hear moving into the future. Bundling. Bundling groups together codes that are related to a procedure. And bundling is related to the CCI edit concept that I just talked about. Unbundling, again, related to the CCI concept that I just mentioned. Unbundling is coding and billing numerous CPT codes to identify procedures, usually described by a single CPT code. Upcoding, coding to a higher level than supported by documentation. Upcoding usually relates mostly to evaluation and management services, but I guess in essence could relate to any type of CPT procedure that is being reported. Downcoding, coding to a lower level than what is supported by documentation. Something to keep in mind is that unbundling, upcoding, downcoding, they could all be considered fraud in the billing world. A lot of times I will have providers try to downcode for services because they think that if they stay in the lower evaluation management code ranges that they won't be flagged for audit. However, that's just not true. You want to make sure that you're coding appropriately for the service that is provided. Do not upcode, do not downcode, do not just stay status quo, like don't keep your coding levels flat. All of those things could be considered fraud. You may not be intentionally doing them, but again, it is most important that you code and bill appropriately for the services that you have provided. So let's switch gears to the modifiers that I've mentioned. Modifiers are included in CPT and they are 2-digit numeric or alphanumeric extensions. We use modifiers in CPT to indicate some of the following: that a service or procedure has either a professional or a technical component. And this is a really important concept here for our cardiology providers, our orthopedic providers, our radiologists. You're going to see CPT codes could be reported with a professional only modifier, which is modifier 26. And we report professional only services if the service was provided in a facility type setting and has both a professional and a technical component. A really good example of this from a cardiology perspective would be an echocardiogram. So if you're doing an echo read in a facility setting, so if you're reading all of the echoes, let's say, that were provided in the hospital inpatient setting, your component of that echo read is going to be reported with your CPT code, which for just a straightforward echo is 93306. And then we would put a modifier 26 on there to tell the insurance company that we're only billing for the professional read of that service. The hospital or the facility is going to bill the same CPT code, but they're going to report that CPT code with a modifier TC that indicates they're billing for the technical component of that procedure. The hospital bills for the technical component because they are responsible for all of the overhead and maintenance of the equipment, in addition to the salary of the tech that's taking or performing the actual echo itself. So when you take the professional component fee and the technical component fee, they would match up to 100%. A service or procedure that was performed by more than one physician can be reported with a modifier. And you see this when you have procedures that require a co-surgeon or an assist on a case. We might use a modifier to report that a service or procedure was increased or reduced. So if we have a CPT code, let's say for orthopedics, for example, we take a patient into the OR and we're going to do a revision of a total knee replacement. And that patient is morbidly obese. That procedure is going to take more skill, more time, more effort in the OR. However, there's not a different CPT code that we would report for a patient who's morbidly obese versus a patient who is a non-morbidly obese patient. We would use a modifier 22 on that morbidly obese patient to define that the procedure was more extensive, more difficult than your typical standard case. Vice versa from that, we might use a modifier to report that a procedure or service was reduced. A good example of this is if you administer anesthesia for a patient. Let's use cardiac catheterization, for example. We take the patient to the cath lab, we've sedated that patient and administered the anesthesia, and let's say the patient's blood pressure drops significantly. That puts the patient at risk for moving forward with the procedure. In that instance, we've already performed the anesthesia on that patient. We've already prepped that patient for the procedure. In those instances, we can actually report that service with a modifier 53 for a discontinued procedure because we've already blocked the time, we've booked the OR, we've started the prep on the patient. We don't want to say that we don't want to not bill for the service because we started to provide the service. So we're going to bill for a portion of that procedure, if you will, and we're going to report that with a modifier 53. We might report that a service or procedure was performed more than once. A good example of this is if we have a patient who comes back for a repeat x-ray on the same day, we can report that with a modifier. We might report that a procedure was performed bilateral. A good example of this would be bilateral knee injections. So if we're doing bilateral knee injections on that patient, it's going to be the same CPT code 20610, but we're going to put a modifier 50 on that to tell the insurance company that it was a bilateral procedure, and then we'll also increase the fee on that service. And we might just have some other modifiers that report for unusual events that occurred during that visit. Here are some examples of the most commonly used modifiers that we see in the physician practice setting. So we have modifier 22, which is that increased procedural service modifier. We have a modifier 24, and this is a modifier that we would use to report a new problem. We're evaluating a new problem during a post-op period. We have a modifier 25, and this is one that I'll talk about a little bit here. So modifier 25 is used to report if you're doing an evaluation and management service that led to the decision to do a minor procedure, such as a joint injection. You evaluated that patient, you evaluated, let's say, their knee, and you decided, hey, you know what, you're a really good candidate for an Orthovisc injection. We can go ahead and do your first injection today, and then we'll have you follow up every so often, whatever the time frame is appropriate for that patient, to have your second, third, so on injection of your Orthovisc. So in that first encounter with the patient, you're going to bill for your evaluation and management service. You're going to put a modifier 25 on there to say, hey, this evaluation led to the decision to do this injection in the office today. So you'd have your modifier 25 on your evaluation and management code, and then you would bill your 20610 for your joint injection. Modifier 26 talks about the professional component only, and I gave that example with cardiac echo. Modifier 51 is something that you might hear about, but we don't typically report it because most insurance companies have modifier 51 logic that they apply to claims processing themselves, so they ask that we don't actually report it on our claims. Modifier 52 for reduced services. Modifier 57, the decision for surgery. So there is a little bit of a difference between a modifier 25 that led to the decision to do a minor procedure and the modifier 57 that leads to the decision for surgery. So going back to an orthopedic example here, you might have a patient that comes in to the emergency room. They fell and they're having significant hip pain. The emergency room physician requests your consultation, the orthopedic consultation in the emergency room. You go down as the orthopedic surgeon and evaluate that patient, look at imaging. Yeah, you have a hip fracture. We need to take you to the OR to fix this. You're going to bill for that initial evaluation in the emergency room, and you would put a modifier 57 if that evaluation led to the decision to take the patient to the OR for a major procedure. So we use modifier 57 on evaluation and management services that led to the decision for a major surgery. We use modifier 25 on evaluation and management services that led to the decision for a minor procedure. Modifier 58, we could use this to report on a staged or related procedure during a post-op period. Modifier 59, we can use this in some instances to unbundle for services. It's going to depend on if the procedure was performed on a separate site, through a separate incision, separate anatomical organ, separate encounter. You might have a patient that you take to the OR in the morning, something happens, you have to take them back to the OR in the afternoon. You'd have two separate encounters that we could use modifier 59 to report that. Modifier GC, which I'll talk about when in a different module for this class where we talk about teaching physician services. And then as opposed to using the modifier 50 that I had mentioned for bilateral procedures, we might report some procedures with an LT or an RT modifier to define that laterality. So the last piece I'm going to touch on in this module, and I just go over this very quickly, is the Healthcare Common Procedure Coding System, or what you might hear us refer to as HCPCS. HCPCS codes are level 2 codes that are used by all payers. They are alphanumeric codes, so that's how they differ from your standard CPT code. So your standard CPT code is going to be a completely numeric code, unless it's one of those Medicare G codes, which could actually also be classified as a HCPCS code. And then your HCPCS codes are going to be a 5-digit alphanumeric code. The HCPCS coding system is the coding system that we use to report things such as drugs, durable medical equipment, ambulance services, prosthetics, dental services. In your practice settings, you're going to see HCPCS codes reported for drugs and DME. So those are going to be the two common HCPCS codes categories that you'll see. One of the things I do like to mention here is that from a primary care perspective, especially if you're administering things such as Rocephin, B12, testosterone, Kenalog, all of those different drugs are billable drugs. So make sure if you are providing those types of drugs in the clinic, you remember to bill for those, because if you don't bill for those, you would actually be leaving revenue on the table. And all of those things are billed for utilizing your HCPCS coding system. So that is going to conclude the first module of the coding series, if you will. So in this module, I introduced you to ICD-10 CM, which again is used for your diagnosis code reporting. I introduced you to CPT codes, and we will take a look at CPT codes in more depth throughout some of the different modules that I will be presenting for you. And then finally, we wrapped it up with HCPCS coding, which again is used for your drugs and DME that you might provide in the office. So if you have had any questions that have come out of this presentation, please make sure you jot those down, and we can cover those when we meet on the actual face-to-face portion, or of course you can always email those questions to me. In addition, there are some references that you'll see throughout all of our different presentations. The Medicare Claims Processing Manual, MLN Matters, and the Texas Medical Association are all very good resources that you can tap into for any coding questions that you may have. So thank you very much for your time.